So I'm convinced that this meeting are to sharing our inspector cases. So here it's a full thickness macro hole, DPV under blue. And then I am doing retracting door technique that I learned from my friend Mahmoud, Dr. Tamer from USA. I moved to start with inferior peeling under the macula and with H, superior H. And then when we fold the flap under the macula, it goes like this video in the bottom. And then we do fax, and the flap will cover the hole. And then I move to the extensive peripheral vitrectomy, and at this moment, I accidentally injured the retina and the choroid. And we have heavy blood, and I stop operating and I pray for stopping bleeding. So then I increase the air, and I try to aspirate the bleeding quickly to avoid the contact bleed with blood with the flap, to protect my flap. And then I continue to remove blood around the flap. And then to stop the bleeding, I use laser. To upload the video, you can scan the QR code, and then I do fax. And again, like said my dear Ahmed, less is more. So I am convinced that this kind of meeting and this kind of session is not to share our best video, but our inspected cases, to talk and to discuss and to sparring discuss with us. So for this, what do you do about extensive vitrectomy, based vitrectomy in these cases with macro hole? We have to stop, or we have to do extensive vitrectomy under the base?
I think that in macular hole surgery or macular work,
Yes.
you don't need to go so far for deep vitreous-based dissection for two purposes, because usually these patients are phakic, and you have to chance to hit the lens during this deep vitreous-based dissection, and the target behind that is very low. I mean, what you gain from that is very low. The other point is you can get peripheral retinal breaks, because this area is very strong in attachment, and you end by recurrent retinal attachment in a case of a simple macular hole.
So the question, where we stop the vitrectomy? So
I think
until which level?
I think you have to attach the posterior hyaloid to the level of the equator. The area which you don't need to depress or do deep scale indentation to reach it. There's no point to go for that.
And you think there's no problem with gas tamponade when we leave a lot of stuff of vitreous around, and then there is a retraction of this vitreous and colonized by cells after several
I think for macular hole, you don't need extensive tamponade. Even some surgeons won't put the patient at any time in long-term prone position. So I think that you need a large bubble. Even with the smallest bubble, and the patient is in the prone position, there will be some macular hole tamponade.
Okay, thank you. What do you think, Ahmed?
Yeah, I would second this. I think it's less is more, and keep it simple. And we've learned from ochriplasmin, where they just injected ochriplasmin. did not remove any vitreous. It didn't work, right? But it did not create so many retinal tears. So the risk of retinal tears was very small.
Okay.
We also learned from pneumatic retinopexy, again, it works in about maybe 70%, but the risk of new retinal tears where you're leaving all the vitreous and putting gas is small. So I think less is more. I do like what I call a businessman vitrectomy. I just remove the hyaloid as far as I can if it goes. If it stops, then it stops. I would try. If it stops, then I would not challenge nature. Stops at the equator, fine. And I would remove the vitreous that I can see, peel or whatever, and then after that search the whole retina and put air and then gas. So I think keeping it simple.
Yes, I agree.
I
with you.
agree.
Thank you.
Thank you so much. Any questions from the yes, please, Dr. Hassan and Dr. Hazazi, if we can get you here. And Walid, if you can sit here as well with us.
Yeah, it's great to mention this point. To which extent that you will reach the, to do vitrectomy. Some people, they are advocating the complete vitrectomy, which will never be there. So do not crossing whatsoever. This is the most rules that you need. Don't cross with your instrument to go to the periphery there. This is important. Do as much as you can see, as Dr. Ahmed mentioned that. Usually, when I see a vitreous with my tip, I can take it. That's what I do after the core vitrectomy. It should be simple. Even for complicated types of diabetic retinopathy, we don't need to do whole of the, because I saw trends now. Put your chandelier, make, if the lens is there, it's too difficult to go. Sometimes the vitreous at the vitreous base, it's not the same as that you see, at the core vitrectomy or the equators. So usually the vitreous there is very sticky, and this is the area where you are looking for the problems.